everyone. We're going to give it a minute or so. People are still trying to log into the webinar. But in the meantime, if you'll put in the chat where you're calling from so we can see where you are in the world, that'd be great. Okay, well, we're going to get started. Hello again, everyone, and thank you so much for joining us today. My name is Catherine Blackwell, and I'm the Chief Health Equity Officer for the Allergy and Asthma Network. Welcome, welcome, welcome to this afternoon's webinar. We're in for a real treat today as we have Dr. William Berger as today's presenter. Now, we have a few housekeeping items before we start today's program. First, all participants will be on mute for the webinar. And we're going to record today's webinar and post it on our website within a few days. And you're going to be able to find all of our recorded webinars on our website at allergyasthmanetwork.org. And all you have to do is scroll down to the bottom of the page to find our recorded webinars and any upcoming webinars that you might be interested in. Now, this webinar is going to be an hour, and that includes time for questions. And we're going to take those questions at the end of the webinar, but you can put your questions in the Q&A at any time. The Q&A box is right at the bottom of your screen there. And we're going to have someone monitoring the chat if you have questions or you need some help during the presentation. We're going to get to as many questions as we possibly can before we conclude today's webinar. This Advances webinar is in partnership with the American College of Allergy, Asthma, and Immunology. ACAAI offers CMEs for physicians and attendance credits for all others. You can create a free ACAAI account and obtain CME or attendance credits through the member portal for Advances webinars. All attendees are going to be offered a certificate of attendance, and no other continuing education credit will be provided. Now, a few days after the webinar, you're going to receive an email with supplemental information and a link to download the certificate of attendance. We're also going to try to add it to the chat. So let's get started. Today's topic is chronic urticaria, meeting patients' needs on their journey to diagnosis, management, and treatment. Chronic urticaria are hives that occur most days of the week for 6 weeks or more. It affects more than 500,000 people in the United States. Today, you'll learn more about the difference between acute and chronic urticaria and how it's diagnosed, how it's treated, and managed long-term. It is my esteemed pleasure to introduce our speaker of the afternoon, Dr. William Berger, board certified in both pediatrics and allergy and immunology. Dr. Berger founded the Allergy and Asthma Associates of Southern California Medical Group in 1981 in Mission Viejo, California, where he practices both adult and pediatric allergy. Dr. Berger entered the field of medicine because he wanted to make a positive difference in the lives of others. His commitment to improving patient care has extended beyond his practice to clinical research, publications, leadership in professional organization, and his work with Allergy and Asthma Network. So, Dr. Berger, thank you so much for being here today. It's great to see you. I'm going to turn it over to you now.
All right. Thank you, Catherine. Well, thank you, everybody, for taking some time out of your busy schedules to learn about chronic urticaria. The mission of our sponsor, the Allergy and Asthma Network, is to end the needless death and suffering due to asthma, as Catherine mentioned. And we're looking to needless death and suffering due to asthma, allergies, related conditions through outreach, education, advocacy, and research. As mentioned, I was medical director for the Allergy Asthma Network and founded Allergy Asthma Solutions, which is a group in terms of helping organizations to develop programs for allergy and asthma. I've worked with, in disclosure, with Immune Therapeutics, which is a company developing new treatments for food allergy, and otherwise no other relationships are concerned. And so what we're going to talk about today are comparing and contrasting the presentation and evaluation of both acute and chronic urticaria, talk a little bit about the step-up approach to treatment and the new guidelines in terms of directing management of this problem. So what is urticaria? Well, urticaria are wheals that have central swelling and reflex erythema. They can vary in both their size and shape from very, very small to large areas. There's a surrounding area of erythema. One of the classical signs of urticaria is pruritic. Patients are scratching and feels it's itchy all the time. The individual lesions will usually fade within a day or two. Now, comparatively, angioedema, which occurs in about 40 to 50% of patients who have chronic urticaria, is non-pruritic but more painful. It can cause erythema and non-pitting edema. As opposed to urticaria, it lacks well-defined margins and takes longer to resolve, up to 72 hours. When you see a patient with urticaria, in terms of evaluation, one of the most important aspects is getting a complete history. And that history should include time of onset of the disease, the shape, the size, frequency, duration, and of course, the distribution of the urticaria. Any other associated symptoms, such as the angioedema, systemic symptoms that can sometimes help you look for possible causes, such as bone and joint pain, fever, cramps. One of the most important things in terms of inducible urticaria is to evaluate whether there are any physical agents or exercise involved. Very often, you might hear a history that there's a relationship to menstrual cycles. We certainly want to find out if it's related to any foods or drugs that the patients are taking, and whether the patient has had any previous or present infections or is under a lot of stress. And of course, if they've received any previous therapy, and if they have, what's been the response to what medication, what dosage, and what duration, and if any previous diagnostic tests or procedures have been done. It's also very important to get a personal medical history of any infection, whether there's any history of autoimmune disorders or any atopic conditions, such as allergic asthma, atopic dermatitis, allergic rhinitis. Family history sometimes can give you a clue as to what might be going on. And of course, you need to get a social history to see if there's any possible exposures that the patient may not realize might be having an important aspect of their disease. And of course, any occupational history. Where are they working? What type of hours do they do? What kind of things are they coming in contact with? And in terms of review of systems, as many of you know, thyroid dysfunction very often has been associated with urticaria, connective tissue disorders, autoimmune diseases, and immune dysfunction. Now, as was mentioned by Catherine previously, we want to differentiate between acute and chronic urticaria. Acute is defined by the new guidelines as occurring less than 6 weeks. Recurrent episodes if exposed to the same trigger. And in acute episodes, you look for possible IgA-mediated triggers, such as foods that they might have an allergic response to, medications, and classic medications are usually the NSAIDs, the non-steroidal anti-inflammatories, which include ibuprofen and other related Motrin, Advil, those types of over-the-counter medications, and naproxen. So a lot of patients don't realize that if you take something over the counter, that doesn't necessarily mean it doesn't have a pharmacologic effect that needs to be evaluated. Also, if the patient has been on immunotherapy, very often immunotherapy can cause urticaria. And then also, you might want to do some immunoassay and do some scratch tests, allergy tests to see if there's any possible allergens that are involved. In addition, there are non-Ig mediated triggers, such as virals, which is very, very common, especially in the pediatric age group, physical triggers, and toxins. And I mentioned scromboid, that's usually from bad fish. where it can actually cause you to develop hives and redness of your skin. And you want to know whether the patient it's chronic or whether it's spontaneous. As I said, less than 6 weeks is considered acute. And the treatment usually involves using antihistamines, glucocorticoids, hopefully in very small amounts. And of course, you want to avoid any presumed triggers. Now, chronic is over 6 weeks, recurring, usually periodic, and can be associated with angioedema, but in many cases is not. Can occur with systemic illnesses such as autoimmune disorders and infections, and also with disorders that affect the mast cells and the basophil, causing activation. For example, activation syndromes that can cause the release of histamine and other inflammatory mediators. And mast cell disorders are a very high concern for patients who have hives. Immunoassays and skin prick tests usually give you no additional information, and according to the guidelines, are not recommended. What's interesting is these patients have been found to have autoantibodies, 30 to 50% against the Fc receptor on the mast cell, and about 5 to 10% antibody against IgE. And when you look at acute urticaria, these are some of the things that that you would think about, whether there's any contact, whether there's been any physical, and we'll go into what those physical urticarias are, food allergy, adverse reactions. Those of you who are in allergy clinics know that you can get hives from allergy shots if the dose is a little too high or the patient's having a reaction. As I mentioned, adverse drug reactions, that includes opiates, which are very often cause hives, ACE inhibitors, and as I mentioned before, the NSAIDs. Papular urticaria usually caused by insect bites, and of course, this can be due to scabies, fleas, or bed bugs. Infections, especially EB virus, Epstein-Barr, or any food or contaminated foods where toxins such as in scombroid poisoning. Acute urticaria and angioedema, you have to be concerned that this may be the sign of anaphylaxis. So if there is an acute episode with angioedema and having other systemic symptoms, including pulmonary, wheezing and coughing, gastrointestinal, very often patients will have complaint of stomach disorder, that they're having stomach pains, nervousness, a feeling of impending doom, and any cardiac changes, especially a drop in blood pressure and increase in heart rate. Needless to say, prompt treatment with epinephrine. Many of you know that there are injectables, and there's a newly approved intranasal form of epinephrine. So either the auto-injector or the nasal spray should be prescribed if there is concern for possible anaphylaxis. Now, chronic urticaria occurs in at least 100,000 adults. Global, as you heard, the numbers now are much higher. Global prevalence is somewhere up to about 3%. Women, unfortunately, are affected much, much greater than men. The usual age group is in the 40s. In other areas, it can be of the world, we've seen it in the 50s and 70s. And with chronic urticaria, it's not unusual for last several years, anywhere from 2 to 5 years. About half coexist with angioedema. About 35 to 50% do resolve within a year. Now, chronic urticaria may or may not occur with systemic illnesses such as autoimmunity, infection. As I mentioned before, immunoassays and skin prick tests are not normally recommended. Very often, we really can't determine a clear pathologic mechanism, but we do want to look for any inflammatory infiltrates, any autoantibody production, and be able to assess whether there's any mast cell or basophil dysfunction, such as any kind of mast cell disorders. Also, we want to exclude other diseases and differential diagnosis, and we want to understand, and there's a much greater concern now about really being evaluate the disease activity, the impact and control, because patients with chronic urticaria really have an important impact on their quality of life. In some cases, it's been compared to the same effect of quality of life as coronary artery disease. And of course, we want to do make every effort to identify any triggers of exacerbation. In terms of angioedema and isolation, first question, of course, is there a family history? Because there are forms of hereditary angioedema. We want to know if there's any comorbid disease. We know that autoimmune diseases, malignancies, and thyroid dysfunctions can sometimes present with angioedema, whether the patient is using an ACE inhibitor as treatment for high blood pressure. Are there any physical triggers? What's really important is to be able to see whether there is anything that you can identify, and we'll go into that in just a couple of minutes. So there's inducible and spontaneous. Predictable sites of involvement. Is there any particular site that seems to involve? If it's around the joints or around the eyes or any particular area, then you need to have a further investigation. And of course, if there are any systemic symptoms, eosinophilia sometimes can lead you towards certain types of eosinophilic disorders. And in terms of angioedema, measuring C4 and C1 esterase inhibitor to determine whether the patient might be suffering from hereditary angioedema. One of the other vasculitis, these types of urticarial lesions are painful or burning. They're usually palpable and they're non-blanching as opposed to chronic, as opposed to traditional urticaria. They can persist for several days. And when they do resolve, there is residual hyperpigmentation, which you don't see in classical urticaria. One of the things that you need to do is to consider getting a serum complement, and you should work with a dermatologist, or if you have the training, to do a skin biopsy to see if under examination where there's signs of leukocytoclastic vasculitis. And then other disorders in terms of low complement, arthralgias, glomerulonephritis, uveitis, episcleritis, all of these autoimmune types of disorders, and also looking for obstructive lung disease and those where there are normal complement levels. Okay. Now let's talk about the pathophysiology of chronic urticaria. It is basically a mast cell and basophil mediated disease. The precise mechanism is unclear, but it's definitely being investigated on a regular basis. But the key thing is the degranulation of the skin mast cells. And when you have degranulation of the skin mast cells, you have release of mediators, and the mediators include histamine, prostaglandin and metabolites, leukotrienes, and platelet activating factor. You also see vasodilation, extravasation, cellular infiltration, and sensory nerve activation. The wheals are due to edema of the upper dermis with dilation and increased permeability of the postcapillary venules and the lymph vessels, upregulation of the endothelial cell adhesion molecules, neuropeptides, and growth factors. You can very often see a mixed inflammatory infiltrate, but what you do not see is any vessel wall necrosis, which you see in urticarial vasculitis. So that's a differential. In terms of non-lesional skin, you want to see if there's any upregulated adhesion molecules, eosinophilic infiltration, or any altered cytokine expression. With angioedema, you will see similar changes, but mainly in the lower dermis and the subcutis. There's a lot of research going on in the area of autoantibody, which is present in about 10% of the patients, and recent investigations think that that number may be higher, 20 to 25%. The type 1 autoimmunity are IgE autoantibodies to autoantigens like thyroid peroxidase, dsDNA, and IL-24. The differentiation, why it's important, is these patients respond very well to omalizumab. They usually can become symptom-free within 7 days of injection. The drug binds the free IgE autoantibodies, and so you therefore have reduced mast cell activation. And we'll talk a little bit more about omalizumab and its mechanism of action. Type 2 autoimmunity are more of an IgG, IgM autoantibodies to mainly the FC receptor site. And as a result, omalizumab does not work as well. You get a slow response due to a slow loss of membrane-bound IgE due to its antibodies to the FC receptor site on the mast cell. Now, here's how we divide chronic urticaria. There's what we call inducible, which is about 20% of the cases of chronic urticaria. This is a result of environmental stimuli and physical triggers on inflammatory cells. And several physical triggers may even coexist. The Jackian practice in 2017 looked at about a little less than 250 patients, and about 75% reported a physical trigger, 36% had a positive challenge test, and about 25% has symptomatic dermatographism. That's where you do stroking of the skin. About 13% had cold urticaria. When patients do describe physical urticaria, these triggers should be, if possible, verified in your office, and we'll talk a little about what some of these tests are. The response can range from mild to severe. Believe it or not, you can have life-threatening, and we'll talk about that, especially cold urticaria patients who develop hives with exposure to cold. If they're immersed in cold water, such as a lake or cold swimming pool, that can cause severe release of mediators throughout the entire body and could be a life-threatening condition. If a severe episode occurs, obviously you want to consider giving that patient epinephrine prescription. The problem is that these types of physical urticarias are less responsive to standard treatments. And so that's why it's so important to try and avoid the trigger. And of course, to have available antihistamines. The spontaneous represents 80%, the majority of the chronic urticarias. However, they're not exclusive. You can have spontaneous urticaria, but may have some inducible symptoms. So let's talk about what some of them are. Well, first, there's what we call aquagenic urticaria. And as you know, aqua meaning water. So it occurs after water contact, usually up to 30 minutes. And it can be any water source. The temperature is not an issue, as opposed to in cholinergic or cold urticaria, where temperature can make a difference. There's a different heterogeneous response. It's felt possibly to ionic concentration or osmolarity of the water. There's no difficulty drinking water. It's basically a dermatologic content. Females seem to be more affected. It tends to occur after puberty, but it's not real clear what the pathologic mechanism is. There are some theories that the water acts as a vehicle for transport of antigens from the stratum corneum to the dermis, and that leads to mast cell degranulation. Interesting enough, studies have shown that if you remove the stratum corneum, you get an enhanced response, and the reaction is determined by the degree of water penetration, how much water actually penetrates into the skin. It's possible that acetylcholine, which initiates sweating and causes open pores, could be involved. Now, this is to be distinguished from aquagenic pruritus, itching with water exposure that you see in, for example, a disease entity known as polycythemia vera, where there's an increase in cells. Cholinergic urticaria, they tend to be very small, pinpoint lesions, and then surrounded by large flares. It represents 5%, which is significant, of all the cases of chronic urticaria, but of the physical urticarias, it's about a third. And it occurs as a result of increase in core body temperature. And the classic history you get is that it occurs with exercise, with hot showers, with stress, sweating. It's felt that it might be an exaggerated response to cholinergic substances. There is a difference in the mechanism of action, secretion of larger amounts of acetylcholine in some patients. Some patients have greater sensitivity, and a lack. It may also be affected by a lack of sweating, hypohidrosis. And it's important that you distinguish this from exercise-induced anaphylaxis. Now, with exercise-induced anaphylaxis, you're going to have other symptoms such as breathing difficulties, possibly a fall in the blood pressure, and all of the signs of anaphylaxis. Here in cholinergic urticaria, it's basically limited to the skin. In exercise-induced anaphylaxis, you're dealing with a possible life-threatening situation. So it's important that you differentiate the two in the history. Now, cold urticaria is interesting, and I do see, a lot of patients. 2% of the chronic urticaria patients have cold urticaria. They have swelling with exposure to cold. There's a primary cold-induced urticaria. There's cold-induced dermographism, cold-induced cholinergic urticaria. There are some familial cold autoinflammatory syndromes, and there are hereditary cold symptoms. One is phospholipase C gamma 2 enzyme, which is very, very rare. Systemic reactions can occur with systemic cold exposure. And this is one of the things that I warn patients who have cold urticaria, is to not be jumping into cold body of water, because they can have mast cell release throughout their entire body and go into shock, and it can be a life-threatening situation. A lot, we do see more of it, obviously, in the colder areas of the country. I'm in Southern California. Not something we see very often, unless they're swimming in cold water. But obviously, where there's snow and where there's ice in the northern regions of the country, you're going to see more of these kinds of problems. Delayed pressure urticaria is urticaria or angioedema with associated about 4 to 6 hours after exposure, but up to 24 in some cases. It affects the areas where there's pressure. So it's going to be on the palms of the hands, on the soles, if obviously where you're walking, and on the buttocks, like if you're sitting right now. It leads to erythematous swelling, which is deep, unfortunately, and painful. And they can have burning desthesia. In other words, the burning is more of a symptom than the itching is. It is very often seen with other physical urticarias or with chronic spontaneous urticaria. Very often these patients have arthralgias. They have painful joints. The skin biopsy shows that it differs from other physical urticarias in which there's no infiltrate seen. What you do see are eosinophil or neutrophil predominant infiltrate. So in a sense, it resembles what you would see in a late phase allergic reaction. Now, what are the triggers of delayed pressure urticaria? Well, things that that put pressure on the skin. So working with tools, sitting a lot, sitting on a bench, believe it or not, clapping your hands, because that causes pressure when you're clapping. Prolonged standing, of course, it'll affect the bottom of the feet, and garments that are very restrictive, such as pants or undergarments that might be very, very tight on the skin. Unfortunately, these patients don't really do well to antihistamines, and they usually require much higher doses. They may even require oral steroids, hopefully just for a few days. There are alternative agents, leukotriene modifiers, and other agents that we're going to talk about, so beyond antihistamines. And this obviously has a substantial impairment on the quality of life. They have to modify their activities, their lifestyle. If they're sitting a lot or walking a lot, they may have to modify that. And also hobbies that involve pressure on their feet, for example, jogging, their type of employment. Are they going to be sitting all the time? The type of exercise they're doing, lifting weights, things like that, and should be wearing loose clothing. Dermatographism, which is called also factitious urticaria. Derm obviously means skin. Graphism is to write. So the way we can obviously diagnose this is by writing on the skin. If you look in dermatology textbooks, there's a picture of someone whose name is Donna, and it's been written with a fingernail on her back. So dermatographism means, again, writing on the skin. It's the most common of all the physical urticarias. It affects up to 5% of the general population. It can occur with other physical urticarias or with chronic spontaneous urticaria. What happens is you scratch the skin, wheal and flare occurs within 5 minutes, and it occurs with scratching or stroking the skin and then can fade within 15 to 30 minutes. Emollients, in this case, sometimes can help you deal with the pruritus that's associated with dermatographism. Solar urticaria is induced by exposure to the sunlight. The severity and duration will vary with the intensity and the duration of exposure. What's interesting is the skin that's more frequently exposed to sunlight is less sensitive and reactive. The skin that's covered is the one that reacts the most to sunlight and having more reactivity. And obviously, one of the ways to help resolve this is to remove the affected skin from sun exposure. It occurs more frequently in females, about 0.5% of the chronic urticaria patients. The key is to use sunscreen and to limit your exposure to the sun. And there are other types of photodermatitis, and so therefore those other types should be evaluated. There's actually something called vibratory urticaria, angioedema and pruritus within 1 to 3 minutes of exposure. it can persist for about an hour, but it does usually resolve in 24 hours. Very often these patients will have headaches, erythema, redness. Triggers are working with things that vibrate, jackhammers, mowing the lawn, riding a motorcycle, running, massage, even bowling has been associated with vibratory urticaria. The ones who are most at risk are people who work with jackhammers and lower lawnmowers, machinists, carpenters, metal grinders. So one of the things that we do mention is possibly gradually building up to a level of activity and reach understanding at what level of activity you can tolerate before the symptoms get out of control. So you want to achieve some type of level of tolerance with progressive exposure, kind of like working out with weights. Start with 5 pounds, then 10 pounds, and 15 pounds, and working your way up. Now, just briefly, these are the challenge procedures for the physical urticarias. For aquagenic, obviously, water applied to the skin for about 30 minutes. Cholinergic this is obviously heat related, so immersion in hot water. Dermographism is very easy. You can see it there on the picture. It's just stroking the skin with the tongue blade. Delayed pressure is putting 15 pounds over shoulder and waiting 10 or 15 minutes. With vibratory, you finally may find another use for your vortex mixer. You apply it to the forearm for about 4 minutes. Cold urticaria is what we do what we call an ice cube test, where we put you can see the positive ice cube test, and you put it on the forearm for about 5 minutes, and then as you take it away, as it warms back up, the hive appears. Solar exposure to specific wavelengths of light, and an exercise is doing a treadmill challenge and seeing if it results in mediated release, and then pruritus, urticaria, and angioedema. Workup. Obviously, clinical suspicion. That's why the history is so important. History and exam. Complete blood count. Look for inflammatory markers such as C-reactive proteins, SED rates. And for many of these patients, you'd want to look for thyroid stimulating hormone, especially if there's a history of thyroid disease. You don't always, although we do that with a lot of patients, the yield is not very high. Obviously, we want to look for any exogenous causes, the foods, the air allergens. But in chronic urticaria, we do ask about it, but usually doing any kind of extensive workup it really is not warranted. So, but I would suggest that you do go over that in the history. The testing for autoantibodies, such as thyroid antibodies, autoantibodies to high affinity IgE, autoantibodies to IgE, and and also the receptor sites is interesting, but the utility and what you do about it hasn't really been established. It's basically just a predictor of whether the Xolair is going to be effective on those patients. So in terms of assessment, what's important is disease burden, the therapeutic response, involvement, body surface area involvement, the severity of the itch. We now have all of these scoring systems in terms of urticaria activity score, angioedema activity score, urticaria control test, and the quality of life. And as you can see here is the urticaria activity score for the sum of it, 7 days. A daily score 0 to 6 with wheals and pruritus scored from 0 to 3, with a weekly summary score maximum is 42. Treatment. Well, obviously, try to avoid the triggers, especially when it comes to physical urticarias. Patients should be advised that if they're having urticaria, that they may want to not use NSAIDs, to use instead other alternative medications. Heat and extreme temperature will certainly aggravate. Tight clothing, opiates we know exacerbate urticaria, and alcohol being a vasodilator will also cause problems, so that you have to limit your use of your intake of alcohol. Topical corticosteroids may be helpful in dermographism, but really not very effective if you have diffuse chronic urticaria. We do not recommend topical antihistamines. Very often they can actually cause allergic contact dermatitis. The pharmacologic treatment follows a stepwise approach. If you look at the bottom on the right, the initial is second generation antihistamines, and then step 2 is going to higher doses of specific antihistamines, 2 to 4 times the dose. So that may be taking 2 antihistamines in terms of taking 2 in the morning and 2 in the evening. However, we don't recommend at this point using first generation antihistamines. Step 3 in the American guidelines is considering other additional antihistaminic medications such as doxepin, hydroxyzine, and then advancing the antihistamines to even higher doses. And then step 4 involves omalizumab and cyclosporin. There are, as I mentioned, guidelines, American guidelines. They both start by using second generation antihistamines. In the guidelines from the college and the academy, there is a step 2 of using second generation antihistamines, adding H2 antagonists, adding leukotriene inhibitors, and then step 3, using other antihistaminic compounds, and eventually omalizumab and cyclosporin. The European guidelines much clearer. You increase the second generation antihistamines. They don't go into using all these other preparations. They go directly to omalizumab. And then if you do not respond to a combination of antihistamine and omalizumab, to consider cyclosporin, which is an immunosuppressant. Okay. Obviously, you want to follow them up on a regular basis to assess their progress and then modify the treatment. It's felt that these patients should be kept on at least 2 to 3 months of treatment before making a step up or step down. 6 weeks is an arbitrary distinction between acute and chronic urticaria, as we mentioned. H1 antagonists are the mainstay. Daily dosing is more effective than using it as needed because they're histamine antagonists. They're much more effective if they are at the receptor site than to give it after the patient has had symptoms. So we put patients on antihistamines on a regular basis. We tend to use, although some people use first generation, the majority of allergists are only using second generation antihistamines. First generation antihistamines, you can see all of the negative aspects: sedation, cognitive performance impairment, anticholinergic effect, some reports of risk of dementia, believe it or not. One of the males are particularly concerned about urinary retention, and in older patients, the Beers criteria in terms of using medicines only that are safe and effective in the geriatric population. Obviously, you got to be careful about using antihistamines, even some of the H2 antihistamines, if patients are pilot or machine operators. So first generations are lipophilic. They have poor receptor selectivity, as opposed to later generations that don't cross the blood-brain barrier, and they lack anticholinergic effects. Here are examples: first generation diphenhydramine, doxepin, hydroxyzine; second generation cetirizine, desloratadine, fexovenidine, levocetirizine, loratadine are the ones that we tend to use more often of the second generations. Oral glucocorticoids, many of you are aware of all of the side effects that are associated, so therefore short-term use is really important to use the lowest effective dose. And be aware of all of the side effects. And patients should be monitored on oral glucocorticoids in terms of side effects or its effect on any other comorbid diseases, for example, diabetes. H2 antihistamines are well tolerated. Very often they can be combined with H1s. The majority of the studies have been done with cimetidine. There are also combinations of famotidine and cetirizine. And the key thing is that cimetidine inhibits cytochrome P450, and that when you combine it with antihistamines, you tend to get higher level of response. Some people will use leukotriene modifiers. There's a possible role of leukotrienes in chronic urticaria. One of the predictors that we ask about is whether the patient is sensitive to aspirin and NSAIDs, because they may be overproducing their prostaglandin, and that using a leukotriene modifier may have a beneficial effect. They seem to work with physical urticarias, cold urticaria, and delayed pressure urticaria. Okay. Next step, if they don't do well on antihistamine therapy, and that may be 50% of your patients, the guideline recommended is to use omalizumab, cyclosporin, and alternative agents such as immune modulators and immune suppressants. Omalizumab has been around since 2002, 2003. It was initially a medicine for asthma, and then was found also to be valuable in urticaria. Many of you know it just got approved also for food allergy. The mechanism of action is not completely clear, but the key thing is that it inhibits binding of IgE to the FC receptor site. And when you reduce the FC receptor sites on the mast cell and basal surfaces, you have less stimulation and release of mediators. There have been reports that it works on some of the physical urticarias and also on the spontaneous urticarias. There's no biomarker right now that can predict the response to omalizumab, other than it's more effective on the type 1 autoallergens. There have been studies, multi-center studies looking at this. Basically, the majority experience recurrence of urticaria angioedema after completion of the study. So it is not something that cures it, and patients do have to stay on it as long as they're having urticaria. And as you can see, this is the itch score compared to placebo. And as you can see, the bottom line, which is the yellow line, is omalizumab given at 300 milligrams appeared to have the greatest effect on the itch severity score. In terms of hives, again, the yellow line at the bottom showed that there was a decrease in the hives as compared to the lower doses. And unfortunately, at the end of 12 weeks, when it was discontinued, you can see the line goes back up. So when omalizumab is discontinued, the response changes, and then you start having symptoms once again. In terms of adverse events, basically primary outcome is that the incidence of adverse events were similar between omalizumab and placebo. And there was, as I said, here again at the 300 milligram dose, you can see that the itch severity was significantly decreased at 12 weeks. This basically shows an improvement in the patients receiving omalizumab as compared to placebo. And then cyclosporin, as I mentioned, is an immunosuppressant. It downregulates Th1 and T cell dependent antibody generation. The key thing when you use cyclosporin is be aware of you have to monitor them for side effects such as blood pressure issues, kidney impairment. They should have creatinine BUNs monitored on a regular basis, and because it's an immunosuppression, you need to be careful about any infection. This is the dose. The optimal duration of therapy has not been clearly defined, and be aware of the fact that different preparations have different levels of bioavailability. Going to go real quickly. Pregnancy. Wanted to let you know that with the first generation antihistamines, it is sometimes secreted in low concentration in the breast milk. So we certainly recommend antihistamines at the lowest effective dose, and that using the second generation antihistamines are preferable in any pregnant patient being treated for chronic urticaria. Studies have shown with omalizumab that there was no pregnancy or fetal complications, so Xolair is safe in the pregnant patient. And there is a Xolair pregnancy registry, and essentially they are looking at that. There were no problems, no major issues. Here you can see omalizumab in pregnancy in terms of the risk, what you would expect, and the general population. The risk was no higher than those reported in the general population. And lastly, be careful about using oral glucocorticoids. It's occasionally used, and the key thing is that the benefit should clearly outweigh the risk for use, and the escalation of care should be on a case-to-case basis. In the elderly, same treatment approach. You should monitor the antihistamines. Be aware of the fact that the older population have other medical problems, prostatic hypertrophy, cognitive impairment. They are on many other drugs. In many cases, they have decreased liver and kidney function, and so therefore you may have to cut back on the dose. And now, last slide, areas for further research. Obviously, being able to monitor the epidemiology in adults and children, consequences of socioeconomic issues, be able to further identify mast cell and basophil activating factors and histologic markers, be able to identify better biomarkers of urticaria activity and mast cell activation, further identify, and there are articles coming out all the time about autoantibodies and chronic urticaria, evaluation of impact of comorbid and its effect on quality of life, why certain patients are resistant to antihistamines, and further long-term safety evaluation of available treatments. And there are multi-center trials going on right now for additional treatment options. The one that is looking the best of all of these is the BTK inhibitors that are already being used in certain autoimmune diseases and appear to have a excellent profile in treatment of chronic idiopathic urticaria, and anti-IL-4, 13 agents, are on the market right now, and anti-IL-5 agents, some of these new biologics, and their role in the treatment of urticaria. So I've tried to get through this as quickly as possible and let you have answered any questions. And with that, I will complete the lecture. Thank you for your time.
All right. Thank you, Dr. Berger. That was a lot of information there. We're going to go to the question and answer session now.
Sure.
And we have, excuse me, a couple of questions. First question for you is, can you review cimetidine versus famotidine to treat chronic urticaria?
Well, they're both H2 receptor antagonists. The one that was taken off the market is ranitidine. There were concerns about some of the cancer. Using cimetidine or famotidine are both H2 receptor antagonists, and using either one is fine. The key is to use it in combination with an H1 receptor antagonist. It's felt that the combination of the H1 and H2 together give you a better clinical response.
Okay. Thank you. Let's see if there's any other questions in the Q&A. Okay, this is terminology that I don't understand, Dr. Berger, but maybe I'm sure you will. It just says immunomodulating as HCQ.
Immunomodulating meaning what I'm not sure what they mean by HCQ.
I'm not sure either. The person just typed in immunomodulating as HCQ. I'm not familiar with that acronym.
I'm not sure what they mean with HCQ. Immunomodulation. Yes, there are immunomodulators. We talked about cyclosporin as an immunomodulator. The biologics are, in a sense, are immunomodulators. If they're talking about some of the ones that all the monoclonal antibodies, they're all immunomodulators in terms of having an effect. For example, IL-4, IL-5, IL-13. So yes, there's research being done. There are ones they call BTK inhibitors. These are immunomodulators, and they're showing real promise in the treatment of urticaria. There are some studies being done, and we may see new medications coming out in the next year or two.
Okay, thank you. All right, I don't see any other questions in the chat. So, Dr. Berger, this has been very, very informative, and just wanted to let you all know that we have several webinars coming up. First, on October 31st at noon Eastern Standard Time, we will welcome Dr. Rajan Merchant to discuss biologic treatments and how they work and who might benefit from them. And then on November 12th at noon Eastern Standard Time, we're going to have another Advances webinar with Dr. Michael Blaise discussing remission of asthma, review of consensus statement. Now you're going to receive an email from Zoom in just a few days with a link to the recording and an evaluation and supplemental resources. And please fill out that evaluation because it'll really help us make things better for you. We want to make sure that what we're giving you resonates and it has meaning to you. So thank you again from all of us at Allergy and Asthma Network, and join us as we work every day to breathe better together. Have a good afternoon.